Hello, welcome to this webinar on chronic kidney disease in primary care, early identification and intervention for improved outcomes. My name is Professor Samuel Seidu. I'm a Professor of Primary Care Diabetes and Cardiometabolic Medicine at the University of Leicester. In this webinar, I'll be joined by three esteemed colleagues: Baruch Itzhak from Israel, Louise from Canada, and Mehmet Ungan from Turkey. Here are our disclosures. So the learning objectives of the webinar will be first, recognizing chronic kidney disease as a silent disease, and as part of the multiple long-term conditions that we see in the primary care setting. We will also endeavor to discuss and apply tools that will help in achieving early diagnosis and management in the primary care setting. And we'll try to integrate all these tools together with medication use and decisions about early referrals. The agenda is going to be as follows. After this quick introduction, I will go through the burden of chronic kidney disease in the primary care setting. And then after that, I will hand over to my colleague Baruch Itzhak from Israel, who will take us through the early identification and stratification of chronic kidney disease in primary care setting. I will then come back and join the discussion on the early management of people with chronic kidney disease in the primary care setting. And then Louise will lead us in the discussions around the referral procedures from primary to secondary care when it comes to chronic kidney disease. This webinar is ACME accredited, and you can claim your continuing medical education points after completion. The activity is supported by an educational grant from AstraZeneca. You would have done your pre-assessment questionnaire, and we will be supplying the same questions after the end of the discussions for you to have a go at them and see whether your knowledge has improved after the discussions. You can send questions or any comments during the panel discussions, and we will try to answer them as the discussions go on. So quickly on the burden of chronic kidney disease, this is now noted to be a public health emergency. We now know that there's over 843 million people with the condition, and the numbers keep rising. So the burden of chronic kidney disease cannot be underestimated. The other worrying point about chronic kidney disease is that a lot of the patients, some data suggests more than 60, and in other data sources, more than 80 and 90 are reported of patients with chronic kidney disease that remain underdiagnosed. So there's clearly an issue, given that the early stages of the diagnosis is done in primary care setting. A lot of efforts have to be made in the primary care setting to foster early diagnosis and management. Delay in the diagnosis can lead to several problems. First of all, for the 10% of patients with chronic kidney disease that end up with renal replacement therapy or transplant, if the diagnosis is not done early, that progression is inevitably going to occur. The vast majority of patients with chronic kidney disease die of other conditions even before they reach renal replacement therapy, such as infections, cardiovascular diseases, for example, heart failure. And if we diagnose these patients early, interventions can be put in place to prevent these from happening. Chronic kidney disease, if it's not diagnosed early, can lead to diminished quality of life and increased the risk of premature mortality. So primary care is our first line of defense against chronic kidney disease. Primary care healthcare professionals have to have the background knowledge and time resources to be able to identify and treat patients very early. There should be greater emphasis on detecting this condition and managing it properly before referring to specialist colleagues. So for a recent survey across Europe, that just knowing or having confidence in the diagnostic criteria and the staging leads to better decisions around the choices of management, pharmacological management, be it using RAS inhibitions or SGLT inhibitors. Those that know the diagnostic criteria and the staging, compared to those that don't know, there is a 6.5 likelihood of knowing when to choose the right medications. And similarly, if you do have that knowledge, you are able to choose the newer agents such as MRAs and SGLT inhibitors compared to those that do not have that knowledge. There are a lot of barriers that we come across in primary care, and some of the barriers that we always hear are workload implications in the primary care setting, lack of symptoms in patients with chronic kidney disease. It's a symptomless disease in the very early stages, so patients do not present with suspicions of chronic kidney disease, and clinicians don't diagnose it very early as a result. So what we suggest to address these barriers will be to educate primary care colleagues about the nature of chronic kidney disease, emphasize on the risk factors such as diabetes, hypertension, cardiovascular disease, and family history of chronic kidney disease, so that patients who have these on their computer records can be screened very early on to diagnose the condition. Educating primary care healthcare professionals about the diagnostic criteria using EGFR and ACR is so important. ACR testing is very poorly done in most primary care settings, and one of the suggestions that have been made in certain countries is to work with the patient so that they can learn to do the testing themselves at home. In these situations, a kit is posted directly to the patient's address, bypassing the healthcare professional. They then do the DIY testing themselves, and if they are found to have evidence of protein leakage in the urine, these results can be fed back to the GP, who would then arrange a confirmatory testing. And if it's confirmed, a diagnosis is made, and the patient is started on appropriate treatment options. To help primary care professionals do this properly, KDIGO heat map has been adapted by ISN Primary Care Diabetes and other organizations, and made very similar to a one-pager. And this one-pager contains all the information that you need about the screening and early identification, management, and referral for patients with chronic kidney disease. This one-pager can be printed and laminated and stuck up on your consultation room boards to remind you when to do what when it comes to chronic kidney disease.
So now we are moving to identification and stratification of chronic kidney disease in primary care, and I'm going to present you a patient journey. So I would like to present David. He is a male of 47 years old. He is a diabetic patient for almost 5 years with dyslipidemia, hypertension, and a newly diagnosed diabetic retinopathy. His blood pressure in examination is 135/85. His body mass index is 26. His A1C is 7.8. His estimated GFR is 90, and his urinary albumin creatinine ratio is 60. In repeated examination tests, he had almost the same results of eGFR 90 and UASR of 60. His total cholesterol is 255. His triglyceride is 350. His LDL cholesterol is 115 milligrams per deciliter, and his HDL cholesterol is 42 milligrams per deciliter. His current treatment is metformin twice a day, Ramipril 5 milligrams once a day, and atorvastatin 20 milligrams once a day. So the questions that we are asking now, Which stage of chronic kidney disease should David be diagnosed with according to his results, his laboratory results? Is it stage 1? Is it stage 2? Is it stage 3A? Or is it stage 3B? Please vote. Yes, so this is the table that you can put David in. So just to remind you, his eGFR is 90 and his UASR is 60 milligrams per grams. So according to KDIGO classifications, David is in stage 2. Is eGFR 90 and UASR 60, so he's actually in the yellow square of this table, meaning stage 2, and that means moderately increased risk in CKD. So now we are going to talk about identification and diagnosis of CKD in primary care, and I will move to Professor Mehmet Ungan, who will present it, and the stage is yours.
Thank you, Baruch. I think we have to start with the risk factors that should trigger screening for the chronic kidney diseases. Yeah, those are the risk factors which we face during the primary care consultations, and mainly hypertension and diabetes are the most frequent risk factors which we face, and when we see them we start to think about it. And of course cardiovascular diseases and the family history are the main clinical risk factors. And we have to also just think about, we have to consider that if there is a systemic disease affecting the kidney, like systemic lupus erythematosus or obesity or some genetic risk factors, environmental exposures to nephrotoxins, demographic, older age, race, ethnicity, those are all factors that we should consider, and especially history of the acute kidney injury. And if we think about them, what tests should be ordered is the question usually, and whether we are applying those, whether we are remembering them or not. I think it's always good to have them on our desk, that we have to order the creatinine and eGFR and urine ACR values, and those are the main tests that we should be considering when we see the risk factors. The creatinine and eGFR ratio measures the kidney function, and if the eGFR is lower than 60, we have to repeat in 3 months or sooner if there is a clinical concern also. And looking at the urine ACR, and it measures the kidney damage, injury, protein excreted in urine. And if urine ACR is equal or higher than 3, we have to repeat 1 or 2 times more over the next 3 months. One test is not enough to make the diagnosis of CKD. And a persistent abnormality for at least 3 months is the key for the primary care mission. I think there is another important point, that the CKD detection should be carried out in absence of an acute intercurrent illness. Otherwise, low eGFR in such scenarios may reflect acute kidney injury and require more rapid evolutions. And I have to mention, not to go for overdiagnosis and just considering some kind of primary care physicians who are not having enough infrastructure like ultrasound. So I think routine use of the ultrasound is not required unless ruling out a cause of acute kidney injury. So how to interpret those results when we get the test results? For me, to be honest, it's not easy to go, when we get the results of these 2 tests, it's not easy to go and to look at in a crowded patient load in a primary care center to check one by one all the tables. But we have to know that there is a KDIGO chronic kidney disease follow-up guideline. So we should be really looking at that in order to refer and in order to be timely acting about the chronic kidney diseases.
So now I would like to open a discussion between our faculty members and to ask them, after we have recognized the importance of identification and stratification of CKD, to understand a little bit what could be the barriers for the GPs to do it correctly and periodically, and what are the solutions that we can offer to do it simply and in a more correct way. So Mehmet, I would like to ask you, as you have finished this nice presentation of you, what do you think could be the barriers of the GPs and how we can overcome them?
Yeah, that is a very good question, because as I told you during the presentation, it is not easy for a primary care or GP or primary care physician, especially if they are overloaded, to use a guideline or kind of a table and to go and to put those results to there. Although one by one, if you consider to use it in that way, you can do that. But if you are a busy one, it's not easy. So most probably the workload is one of the major problems that in use of those guidelines, follow-up guidelines. And also, I can tell you that there are some regions even in Europe that underdeveloped places, rural places, which the people are really working single. And it's really hard for them to one by one check those things. And there is a fear of making wrong diagnosis, or maybe fear of making an overdiagnosis and putting the patient into difficult conditions.
And what is your suggested solutions for that?
Yeah, this is, classical GPs are not very happy, sometimes like me, to use the digital solutions in the daily practice. But then when we start to use it, automatized systems, let's say, like supporting the decision-making, they really help.
Okay, thank you, Mehmet. And I see that Sami is agreeing with you. So please, what is your opinion?
Thank you, Baruch. I was just going to say that, I agree with the suggestion of automation, because GPs are very hard pressed for time, and knowing all these guidelines can be a bit daunting, especially given the fact that they may not just be dealing with patients with chronic kidney disease. They will have patients with all sorts of long-term conditions. So you kindly listed all the risk factors: diabetes, hypertension, cardiovascular disease, and family history as being some of those common conditions. So in electronic medical records, for example, if computer systems can be programmed to identify these risk factors so that the pop-ups will be suggested to the clinician when they open the records for these patients, to consider screening that patient for chronic kidney disease if the patient has all those risk factors but has not been diagnosed yet. So that sort of automation will help GPs a lot. The other thing that I probably just want to say quickly while I have the floor is you also talked about the diagnosis. We do know from the evidence that knowledge of the diagnostic criteria and the staging makes a difference a lot when it comes to giving appropriate management options. And you suggested eGFR lower than 60 and urinary ACR, urinary ACR more than 3. Now, those are very good markers to remember, but you did suggest repeating them 3 months later, and not to just use the acute, numbers, which I agree with. The only thing I would say to that, in addition to my primary care colleagues, is that, especially with the proteinuria, when you have done the urine ACR and you see that the patient's leaking protein, that is a call for action. Yes, we're not saying you should rush to diagnose chronic kidney disease with just one test, but just that one test is a sign that there is something wrong in the system. In the cardiovascular system, it tells you that the basement membrane is damaged and proteins are leaking out. So that can be an early sign of cardiovascular disease. Don't ignore that. In the kidneys, podocyte degeneration is already happening. That's when you start seeing proteinuria. And so when you see that, even if it's a first up, don't ignore that. Please kindly repeat that 3 months later. And if it is still damaged, then you can confidently make your diagnosis. But don't ignore a one-off testing. Repeat it at least 3 months later.
Yeah, I agree. And thank you, Sam. And I think also one of our advantages as GPs that we see often our patients. So in case we are losing it in the first visit, we can see it again in the next visit of the patient. This is a benefit for us. So now I'm going to our specialist nephrologist, Louise. What do you think, Louise?
Yes, thanks for this. And I agree with the earlier participants' comments. I think the biggest barrier has been the measurement of the ACR, because we do blood work perhaps, more commonly. But I do think, as was just mentioned, that the ACR is often not, even when we're aware that they're diabetic or hypertensive and they're being screened, but unfortunately not including the ACR. So I think, how do we put that in our minds? I think kidney, so urine, there's an association there. So hopefully we can start to just, I know AI is important, but also that we start to think of that with it. And again, I think when you're talking to patients, because many times they're having to, urinate in a cup, that you have to tell them that it's like, you're examining, as we heard, a breach in the kidney, or as I say, that the car is leaking oil. So, that we're looking to see that there's some damage. And as we've already heard, the ACR, or having this protein leak, is an early indicator of kidney damage, kidney disease, and often occurs before any change in creatinine. So as we just heard, it is an indicator, I would suggest, of vascular disease when we see that small amounts of proteinuria without change in creatinine. And again, as we heard, an increased risk of vascular disease, whether we say cardiovascular, cerebrovascular, and now good evidence to even support that that's a signal for peripheral vascular disease may be also in the works. So again, I think the three, as we were saying, the diabetes and hypertension, that likely encompasses more than 50%. So if we can get those two categories out, vascular disease, your patients that are coming with cardiovascular disease, peripheral vascular disease, screen those, and the family history, I think that would capture, likely close to 75%. And then the AI or other techniques that you have, just gaining practice over time, understanding those other causes. But I think get those big ones in your bucket, first of all. Get your own system of doing both creatinine and ACR, again, that repeat. And then, you'll gain, as lower the creatinine, the higher the ACR, the increasing in risk. Thanks, Baruch.
Thank you very much. So if we are going back to our case presentation of high risk, so he's need a close follow-up and treatment already.
Yes, he's right in that yellow category to treat. So really that is, make sure that blood pressures are under good control. If they're diabetic control, lifestyle, of course. We have good evidence of, monitoring lower salt diet, regular movement, as I say to patients. And again, looking for other risk factors, recurrent dehydration if they're working out in fields or hot work environments, or use of anti-inflammatory agents to look to see if there's any other causes that could be contributing. So gets to be, kind of that you've got them in that yellow zone. Definitely family doctors need to look at that and treat that appropriately. Thanks.
Thank you very much, our faculty members. Now we are moving to our next session, and is the management of CKD in primary care, a patient journey and we will focus on lifestyle modifications and treatment. We are now with our patient David. 10 years later, he is now 57 years old. He has diabetes for 15 years, dyslipidemia, hypertension, background diabetic retinopathy. His blood pressure now is 140/82. His body mass index is 28 and the A1C is 8.2. His estimated GFR is 55. His urinary albumin creatinine ratio is 156 milligrams per grams. His total cholesterol is 209, LDL cholesterol 115 milligrams per deciliter, HDL cholesterol 42, and triglyceride 270 milligrams per deciliter. Current treatment of David is sitagliptin on metformin extended release 50/850 twice a day, ramipril 5 milligrams once a day, and atorvastatin 20 milligrams once a day. So let's put David now under stratification. So according to KDIGO classifications of the CKD, and according to the eGFR and UACR, David is now on CKD stage 3A. His GFR is 55, his UASR 156, and the star is on stage 3A. That means he is now on high risk, and we have to do something with his treatment. So our question now to the audience: which of the following treatments would be suitable at this point? A, stop sitagliptin metformin and A, the GLP-1 receptor agonist plus metformin. B, increase sitagliptin metformin to 50/1000 twice a day and add an SGLT2 inhibitor. C, continue sitagliptin metformin 50/850 twice a day and add an SGLT2 inhibitor. Or D, increase sitagliptin metformin to 50/1000 twice a day and add a mineralocorticoid receptor antagonist. So please vote. So I will pass on now to Sam in order to speak about lifestyle modifications and treatment. Professor Seidu, the stage is yours.
Thank you very much, Baruch. Certainly in the primary care setting, one of the things that we do very well is lifestyle modification with the assistance of our healthcare assistants and nurses. We do this part really well. So in a patient like this, you have to emphasize on their dietary habits. And so the dietary habits has to include protein restriction to about 0.8 grams per kilogram body weight. But of course, this patient is not on dialysis yet. If they were, you probably want to increase that to 1 to 1.2 grams per kilogram body weight. In addition to that, sodium restriction is also necessary. The WHO recommendation of less than 2 grams per day is to be emphasized in this case. Physical activity is important. Aiming to get your 150 moderate to vigorous physical activity a week is important. Evidence shows that increasing your physical activity levels can decrease your proteinuria. And then, of course, the same thing applies to smoking cessation. These patients have already had cardiovascular events. So smoking cessation is not just going to be helpful for reducing the cardiovascular risk, but also the proteinuria. Get the patient to stop smoking. And of course, weight management, getting the patient to lose weight would also help. When you have done all this, then we will now jump into pharmacotherapy. And from the KDIGO diabetes kidney disease recommendations, we now have very clear pathways of adding medications after your lifestyle. So in this patient, you could consider an SGLT2 inhibitor, given that the eGFR is more than 20, you can continue on to dialysis and even transplant in some cases. Metformin, the eGFR is still high, above 30, so you can safely continue to metformin. And the patient's metformin dose can actually be optimized because the A1C also needs reducing. RAS inhibition, the patient is on ramipril, which is good. 5 milligram ramipril can also be optimized. A lot of the time in primary care, we are quick to start ACE inhibitors and ARBs, but we don't optimize to the maximum tolerated doses. So these patients, ACE inhibitor could also be increased. And finally, given that the patient has had an event, and indeed, just by having chronic kidney disease alone, they are at a very high risk of the subsequent cardiovascular event. So you've got to optimize the cholesterol, lipid lowering therapies as well. And there are a lot of options available now in addition to your statins. PCSK9 inhibition, you can refer to your specialist to help with that. In other areas where you have bempedoic acid and icosapent ethyl, all of those are options that you can use to get your cholesterol down. If you have, done all this, you now have to focus on whether this patient needs optimizing of their glycemic control, in which case a GLP-1 receptor agonist can be added. And also, if the proteinuria is so significant, despite your ACE inhibitors and ARBs and SGLT2, then your non-steroidal MRAs could also be added at this stage. So the KDIGO 2022 recommendations regarding ACE inhibitors and ARBs for a patient with diabetes, hypertension, and albuminuria, it is recommended that you should have your ACE inhibitors and ARBs. If you have a patient with diabetes, albuminuria, but the blood pressure is normal, you may still consider your ACE inhibitor just because of the proteinuria and titrate these patients to the maximum tolerated dose. And there is strong evidence of, doing your ACE inhibitors if the proteinuria is more than 300 milligrams per gram or the eGFR is less than 60. But in those with diabetes and hypertension and the ACR between 330 to 229, that's a level of the evidence. Just go through the evidence that have driven the use of SGLT2s in addition to your RAF inhibition. Back in 2009, we had a presentation of Credence trial, which used canagliflozin in patients with type 2 diabetes, all of who also had ACR more than 300 milligrams per gram. Split into two groups, one group to have canagliflozin 100 and the other group to have placebo. And at the end of the follow-up, there was a 30% relative risk reduction with a numbers needed to treat of 21. That was the first trial that showed, renally dedicated trial that showed improvement in the primary outcome, which was much, very long awaited. We hadn't had any news like this since the ACE inhibitors and the ARBs about 20 years earlier. Subsequently, we had the DAPA-CKD trial, again, similar sort of trial design, except that this population had patients with and without diabetes. But this time we used dapagliflozin 10 milligrams versus placebo. And again, at the end of the follow-up period, the composite, the primary outcome was reduced by 39% relative risk reduction, and the composite kidney outcome was reduced by 44%. And this actually just confirmed, the initial data from the Credence trial, but in a much more broader population. And recently, we had an EMPA kidney trial as well. Again, looking at another drug in the group, empagliflozin. Similar studies done, but a lot broader. The population is a lot broader this time. Patients with and without diabetes, and this time also had a significant proportion of patients without albuminuria. And again, we've seen consistent results, 28% relative risk reduction at the end of the follow-up period. So you put all of it together, you put all the data together, the EMPA kidney and DAPA kidney results, and you are seeing consistent, reduction in kidney outcomes, which is now driving the guideline changes that we have seen in the KDIGO. So we did mention, the lifestyle changes and pharmacotherapy. Don't forget the cardiovascular risk reduction, blood pressure control, focus on A1C optimization, and optimizing your ACE inhibitors or ARBs and your SGLT2 inhibitors. In addition to that, there is now a fifth pillar, which is the non-steroidal mineralocorticoid antagonist, pinorenone, the first one in the class, which has been shown to also lead to significant kidney outcomes. And in the next slide, I would just go through that. So for the busy jobbing GP, the mode of action for pinorenone is just basically inhibiting inflammation and fibrosis in the kidneys and in the heart. And that leads to some positive outcomes, as you can see in the next trial that I'm going to present. Trials regarding pinorenone were two, Fidelio DKD and Figaro DKD. The Fidelio DKD was a renal dedicated study which looked at chronic kidney disease progression as a primary outcome. And the Figaro was a cardiovascular outcome trial of that drug. And that looked at cardiovascular mortality and morbidity reduction as a primary outcome. And in both of these trials, statistically significant reductions were noted, 18% in the Fidelio DKD and 13% in the Figaro DKD. And both of these trials showed significant reductions in other secondary outcomes, CV mortality and morbidity, and CKD progression in the Figaro. The trials were pulled together in pre-specified analysis called the Fidelity trial. And in this study, this analysis, there was a 14% reduction in the time to CV, the non-fatal MI, non-fatal stroke, or hospitality for heart failure. And this was statistically significant. In addition, there was a 23% reduction in the time to kidney failure, sustained eGFR decline of more than 57%, or renal death. So as you can see, the evidence is now very rich when it comes to the pharmacological management of people with chronic kidney disease, with or without diabetes. And as I've shown earlier in the KDIGO flowchart, there are a lot of options after your lifestyle intervention, ranging from RAS inhibition to SGLT2 inhibitors, adequate glycemic control, lipid reduction, lipid lowering. And if you do so have increased proteinuria after that, you can add your MRA. And if you still need optimization of glycemic control, a GLP-1 receptor agonist is an option. If you need blood pressure control, calcium channel blocker, in addition to your RAS inhibitors, is also adequate. Thank you very much. And I'll hand back to Baruch.
Yes, Sam, thank you very much for this interesting overview about the treatment options in CKD. And you gave us a very clear message of treating our patients in a holistic way. Not only the kidneys, also other risk factors, and it's very important. But still, I would like to ask you why we have still this gap of treating our patients in the best way. What do you think? What solutions you suggest for overcome this gap?
Yeah, so I think, Baruch, thanks. It's a great question. The knowledge is increasing in this area, but education has been one of the things that has been lacking. And it wasn't necessary because for 30 years, we have had RAS inhibitors, which we have been using to control blood pressure. And indeed, we've also known for years that even in normal hypertensives, if there is proteinuria, RAS inhibitors are still useful. So we have been doing that already. And there really was no point to want to do anything else until recently. We've now got the SGLT2 inhibitors and the MRAs also coming. So education about the new additions is important. Additionally, the other barrier for treating is just the workload. Like we said earlier, our GPs have a lot of other chronic conditions that they have to manage at the same time. and learning about all of these and addressing them in the same clinical setting can be a bit daunting. Thankfully, a lot of these conditions tend to go together. There is something I call the concordant long-term conditions. Conditions like blood pressure, chronic kidney disease, heart disease, and diabetes have similar pathophysiological pathways, and for that reason also respond to similar interventions, be it lifestyle interventions or pharmacological therapy. And so having the patient in one clinic, you can actually address a lot of these things at the same time if you know the right therapeutic options to consider.
Thank you, Sam. Louise, what do you think?
Yes, thanks, Sam, for that excellent presentation. I think, I think it's clear to me to make things happen, we have to make them extremely simple. So I think your messaging, Sam, was excellent. And I think if we think of pillars, we did describe sort of diabetic kidney disease. And I think we're starting to think of pillars with that. We're thinking of pillars now in heart failure. And we're, as you said, we're seeing some consistencies. So regardless of the type of CKD, we can still focus on that lifestyle, the reduced salt diet, as we heard of, the movement, obesity, or addressing obesity if it's a concern as broad statements. Again, blood pressure management is a consolidated statement across all vascular disease. Certainly, if there's proteinuria or diabetes, we look at ACE-ARBs as first line. So I think that's a consistent message. SGLT2 inhibitors are indicated for both non-diabetes and diabetes, as Sam so nicely showed us. I think important areas we don't use it in are type 1 diabetes, in people who are on significant immunosuppression, people that have perhaps these recurrent genital fungal infections, some concerns that if someone's got instrumentation in with their bladder, and in people who've had DKA. So relatively short list of who not to use it in. So again, starting to be broad pillars that encompass both CKD, vascular disease, and heart failure. And I think keeping those pillars kind of front and center, adding in the SGLT2, certainly in diabetes, we'll consider a second line finerenone, some early evidence about the GLP-1 agonists and outcomes. But we start to get a toolkit and we get familiar with those tools. We likely just need to pick one SGLT2 inhibitor, one ACE inhibitor that we are comfortable with. And then we get a small list of drugs or medications that we're familiar with. And then I think that's the ticket of it. And if you're uncertain, to ask, because these drugs that Sam presented, SGLT2 inhibitors, have been really revolutionary in their outcomes with vascular disease, cardiovascular, heart failure, and kidney disease. So important that it was something new that the primary care may have to do familiarize, have a conversation, listen to a podcast, whatever is the opportunity that best suits you to learn about these new opportunities to reduce our patients' risk and improve their quality of life. Thanks.
Thank you very much, Louise. So if I understand well your important messages, both of you, Sam and you, we have today new medications that are cardio and renal protective, and we should use them in the correct way and early as possible in order to reduce complications in the future.
Yes.
Agree.
Correct.
Yeah. Okay. Thank you very much. So this is David 10 years later. He is coming again to our clinic. He's already 67 years old, already with 25 years of diabetes, still on dyslipidemia, hypertension, background diabetic retinopathy, and already, unfortunately, 3-vessel disease, cabbage operation that he passed 5 years ago. And according to the echocardiography, he has also heart failure with reduced ejection fraction. His blood pressure now is 120/80. His body mass index is 29. His A1C is 7.6. His estimated GFR is now 44. I remind you that he was 90 at the beginning, now he is 44. His urinary albumin creatinine ratio is 500 milligrams per gram. His total cholesterol is 133. His LDL cholesterol 98, HDL cholesterol 40, triglyceride 250. His ECG is normal, but again, in his echo, cardiography, you can see left ventricular hypertrophy and ejection fraction of 40%. His current treatment, sitagliptin and metformin extended release once a day, dapagliflozin 10 milligrams once a day, glyramperide 4 milligrams, ramipril 5 milligrams, furosemide 80 milligrams once a day, hydrochlorothiazide 12.5 milligrams once a day, atorvastatin 40 milligrams once a day, and bisoprolol 5 milligrams once a day. So putting him under the classification of KDIGO according to EGFR and UACR, David has now actually the stage 3B, putting into the table on the squares. Then we can see again EGFR 44 and UASR 500 milligrams per gram. The point is now that he is already on the red zone. Red zone means very high risk, over 300 milligrams per gram albuminuria and decrease of EGFR. So what we are supposed to do now? This is the time maybe to refer him to a nephrologist consultation. And actually, this is the time to hear our colleague, Louise. Louise, the stage is yours.
Thank you, Baruch. So again, it's as the family doctor who we really understand does so much work for so many different conditions. I think this is an important one. And these are sort of standard. I think everyone agrees with these terms to refer to the nephrologist, the specialist, to get some consultation as to the best practice for moving forward, and also to engage with the patient. So again, as you can see on the left, the clear indications an EGFR less than 30, consistent proteinuria greater than 300 milligrams per gram, as we've seen here, or an EGFR less than 45 and proteinuria greater than 30. So again, when we look at that, if we were to mark those out, I'm not sure if you can see my pointer, but all of those take us over into that range of sort of the orangey red color. And if you can read it, it says treat and refer, because of their risk being higher. And again, the last concept I'd like to introduce, if it's not familiar with you, if there is a 5 risk of kidney failure in the next 5 years, that's defined as needing dialysis, transplant, or dying of kidney disease. And for that, we look at a risk equation, the kidney failure risk equation. And if that's greater than or equal to 5%, it does deserve referral. Now, again, these equations can be difficult to remember, and I actually don't think we can do this one in our head, as it has some algorithmic terms to it. But again, this risk equation calculates both 2 and 5 year risk if the EGFR is less than 60, and it may help you to decide about referral. And recommendations or referral are if it's a greater than 5% risk in the next 5 years. And again, it can be used. It's been validated in people across the globe with EGFRs sort of in the stages 3 to 5, so down to close to 15. And it includes not only the EGFR, but also the ACR, as we've talked about being important, as well as the age and the sex. Again, other indications for referral could be unexplained progressive decline in EGFR. And as people age, we do see an EGFR decline. And, it can, as we get older, and certainly if there's any other issues going on, can be about 1 mil per year. And certainly in conditions such as hypertension, certainly diabetes, if they have proteinuria, if we take a population, it's about 3 mils per year. So if you're seeing a patient that you're quite comfortable managing with diabetes that has some significant kidney disease and perhaps proteinuria, but you see that decline is quite quick, so more than 5 mils, again, all of these are hard to calculate exactly, but you're going, gosh, that seems like a more rapid decline. That would be an indication to refer. And again, unexplained significant albuminuria, proteinuria, or hematuria. You might be comfortable managing with some proteinuria in a diabetic or perhaps a little bit of proteinuria in a hypertensive. But if you're a hypertensive non-diabetic patient is spilling a significant amount of proteinuria, that's atypical, probably atypical in your practice. And, sending them along for referral would certainly be appropriate. I think persistent hyperkalemia, high potassium, resistant hypertension, defined as uncontrolled hypertension on 3 antihypertensives, including a diuretic, recurring kidney stones, which is quite a prevalent problem, hereditary kidney disease, such as adult dominant polycystic kidney disease, are all indications for referral. Other complicated things can be anemia that you think might be related to the kidneys, mineral bone disorders, hyperparathyroidism, whether it's primary, secondary, metabolic acidosis, and other electrolyte abnormalities, including low and high sodium. I think anytime you're suspected of this glomerulonephritis or renal vasculitis, if you see blood in the urine that's unexplained, certainly if somebody's having systemic features, they're unwell, you've had recurrent in lung infections, it seems to persist, and you're just thinking something odd is going on, please do a creatinine and ACR and then refer along if needed. And again, I always say, I refer to others when I'm uncertain of my next step. So in neurology, that might be an early referral, in cardiology, maybe less so. So I think we have to use that barometer besides guidelines. And I can, consider you want to use a medication, perhaps you're uncertain about SGLT2 inhibitors, or perhaps you want some new information about finerenone, that, you want to see how the expert uses it. That seems quite reasonable. And managing patients, but you want to review if there's anything new. So, you're quite comfortable managing that stage 3 CKD in a diabetic, but you will hear there's many new things, and you'd like to see the approach of the specialist, and occasionally referring that, what you might say is a standard patient, just to see what those updates are, I think is completely acceptable. And again, I think important, how do we communicate? Everything is about communication. So I've just listed some things there for it. Very important. Sometimes we need patients' emails if we're going to be setting up email communication or doing things via WebEx or something. I think very clear, what's your question? It's not always a diagnostic question. Sometimes you want us to discuss certain aspects of care, letting us know a little bit about their history. If there is an electronic record that can be shared, certainly medications are very important, as well as your contact. And how do you want us to contact you? And many of our colleagues, we contact each other now a bit more electronically than waiting to get through on a telephone. And again, what should you expect from a consultation from a specialist, and in this case, a nephrologist? Well, generally to confirm or reassess that diagnosis. Like, it may look like diabetes, but maybe there's something else going on. So you're asking them, they should be considering investigating further if needed, to do the additional tests and imaging. Again, optimize those risk factors for management to reduce further progression and reduce risk. And again, when we talk about risk, it isn't always just kidney risk. We're really talking vascular risk, because we're one body so much. I often say, if it's good for the heart, it's good for the kidneys. optimizing management of blood pressure, diabetes, lifestyle, obesity now, and known to be an independent cause of CKD, review of medication safety, as certainly additional management strategies for electrolytes, metabolic bone disease, as I've discussed, anemia, and of course, fluid management. Importantly, I say is provide education on chronic kidney disease and progression and what to watch for and what patients can do. They often say, what can I do to help this? And I think sometimes going to a specialist really brings home that this is an important issue and we have to all work together. Depending on the stage, we have to look forward, plan for renal replacement therapy, get support for decision-making. And again, at this stage, many of us are reviewing overall goals of care. This is now getting where we're getting into that pre-planning for looking at renal replacement options. We need to review goals of care, choices, including conservative management, and really working with families. And we have at this stage allied health teams that are often joining, including social works. Thank you very much. And I think I'll pass it back now to our chair, Dr. Baruch, to facilitate further discussion on this. Thanks you.
Thank you very much, Louise, for this comprehensive overview about indication for referrals. But still, I would like to ask you, there are still lack of referrals and barriers to refer to nephrologists. So partly you have mentioned solutions to use in order to increase the referrals if they are needed. But what do you think we should do as solutions for those barriers for the future time, for the GPs, to help them to create a better atmosphere of referrals to their specialists, the local specialists?
Mm-hmm. No, I think it's a very good question. I think if the GPs feel that they could use some support with that, I think, start to send referrals, if possible, to nephrologists. I'm hoping I catch your question right, Baruch. And then, often you have work better with some people than others, or you get better responses from one than the other. And that, I think, helps us to set up that pattern. I also believe that any kind of communication besides a piece of paper, which we still often fax back and forth, seems rather archaic in this age. So any opportunity that there is to actually speak to these people, to set up the community or the team, would be very helpful. So if there are any opportunities, to do CME or any kinds of, to meet and greet with these people, I think that's often when you're at them is to introduce yourself and set up that relationship so that it becomes more comfortable to give them a quick call or give them a quick email to move that forward. Again, I think it's about relationships and building teams in medicine. And I think communication has a great need to be enhanced besides, faxing things and having this communication pathway that never involves people.
And maybe it has also a learning effect between the specialist and the GP. Absolutely. About the same case. Mehmet, what do you think about barriers of referrals and solutions?
I think the lack of the training and education and a lack of the spare time for the GP is a real barrier, I think. And if we are aware about, some certain level indicators, let's say, like those tests, and if we are really on time, I think we can prevent most of the advanced cases, I think. So this is the training and education and collaboration is the most actually biggest problem, let's say. And in some certain areas, I know that it's not easy for the gatekeeping role of GPs to refer the patient easily to the nephrologist, unlike some other developed countries, let's say. This is also a barrier which the system shall allow free of services for the patient to get it from the specialist, to go to the specialist and to get it from the specialist especially. And sometimes some ordering tests are not, if you, actually we are following usually those hypertension and lipids and everything in many countries, but in some countries is even asking tests is not easy for depending on the system where you are. So I can't generalize as a problem, but the main problem is easy, small frame and very, very easy to take messages by nephrologists to the GPs, not making it a huge training, but small messages. They are very important, I think.
Thank you. Thank you both.
So we are continuing with the discussion, and welcoming back my colleagues, Professor Baruch, Itzhak, Louise, Moist, and Mehmet Ungan. This part of the discussion is going to be a live discussion, and we're going to take some questions from the audience. Baruch, just quickly, while we wait for the question, there is one that I was thinking about. Is there any merit in doing the urinary ACR before EGFR when it comes to diagnosing chronic kidney disease?
You mean to start with the USR or?
Yes.
Well,
yes.
First of all, in some systems in our colleagues' offices and computers, we can actually see the EGFR automatically. The computers are giving us the results of the EGFR, and sometimes it's easier. It's the first point that we can follow up and see the patient during time. But I think that we should do also the urinary albuminic creatinine ratio in a dipstick test. It's a simple test. It is not complicated, and still it is very important to combine it together with the EGFR. So I believe that we should do it at least once a year in those patients who are in high risk for a CKD, even if they don't have it yet.
Yes, I was just posing a question to Louise. We are aware that the KDIGO 2023 version is due to be released soon, later this year. Are you aware of any updates that we need to be aware of in primary care at all?
Yes. Well, thanks for that question. I just saw the draft review yesterday and sent it around to my clinic. So thankfully, I've had a look at it. I think it reinforces what we talked about, really the importance of screening and making the diagnosis, as we said, particularly the ACR. And again, I alluded to, but in the updated guidelines, which will be released next year, they really are looking at those pillars of care, similar to goal-directed care we saw with heart failure. So the basics in place, as we said, lifestyle, which we heard so elegantly stated, then layering in blood pressure control, ACE, ARBs, particularly in diabetics and with proteinuria. Then consideration for the SGLT2s in both diabetics and non-diabetics. Again, I did list previously those that are relative contraindications, although there is a study currently calling the lifestyle study, I believe, being conducted in Germany, that will be looking at those populations not yet studied with SGLT2s, EGFRs below 15, transplant, on immunosuppression, and on dialysis. Then they look at sort of the finerenone, the non-steroidal mineralocorticoid receptor antagonist. Again, currently that's just indicated for diabetic kidney disease, but there are studies underway looking at it in non-diabetic kidney disease, looking at it in combination with and without an SGLT2 inhibitor, and also a study looking at it in preserved heart failure, as we did see that change. People were excluded that had heart failure in the trials, but they still found a benefit. So those are the studies I'm aware of with finerenone. The GLP-1s are really of interest. The primary outcome trial trials with kidneys are still to be released, but the secondary analysis of the larger studies such as SELECT have shown a decreased rate of decline of EGFR, which I've alluded to before. So I think it is that layering and then broadening the population beyond just diabetic kidney disease to see which of these would be applicable in non-diabetic kidney disease. So that's what I've read so far. Thank you.
Thank you very much. You are ahead of the game, Louise. Thank you so much for the update. Mehmet,
I was reading ahead.
Yeah, Mehmet, just a quick question. Which cardiovascular outcomes should we be worried about in people with chronic kidney disease? And how should we manage these outcomes in primary care?
Actually, it is. I think in during the video section, we were just discussing about the once you have damage in the kidneys, that means that it should be also in your other vessels, not only on the peripheric vessels, but also in the cardiovascular system, especially. I think that was a very good message of Louise saying that if you have a leakage like a car, a leakage of oil, then that means that there is other problems in the other part of the body, and especially the vascular system. So I would first be really worried about the coronary heart disease immediately. And during our checks, I think it would be nice to focus on the, especially in the coronary heart, and also some kind of insufficiencies in the cardiac system. That's a summary for me.
Yeah, sometimes it's a predictor. It's a predictor for cardiac disease, the proteinuria, absolutely, the microalbuminuria, and you are right.
Yeah. That's a great summary. So just quickly, Louise, just coming back to you again, there is a question of presence or absence of diabetes when it comes to using an SGLT2 inhibitor. From the presentation, it looks to me like that shouldn't make a difference. These drugs work very well in patients with and without diabetes. Would you concur with that? Simple messaging for primary care.
Thank you. Absolutely slam dunk for diabetes, proteinuria, non-proteinuria. In non-diabetic kidney disease, with the exception, as I mentioned, polycystic kidney disease, the high dose immunosuppression, instrumentation perhaps, and type 1 diabetes, it can be considered if there is proteinuria, and defined by that, I think in your units is around 300, and in SI is 30. However, the EMPA kidney did include people that were both diabetic and non-diabetic that did not have protein in their urine. But the only group they included that did not have protein in the urine was if the EGFR was less than 45. So that's the stipulation of CKD without proteinuria. If the EGFR is less than 45, the EMPA kidney, which was the only one that included the non, did show that it reduced the rate of decline of EGFR. And I alluded to that before in the presentation of that sort of 1 to 3 mils kind of expected. It did reduce that rate of decline. So important, that's the evidence we have currently. So in non-diabetic kidney disease without proteinuria, there is evidence to support SGLT2 inhibitor with EGFRs below 45. In part, that was because the study's 3 years, and you wouldn't expect to see much decline in someone with an EGFR above 45 without protein, to all the points you've raised as being the proteinuria really being an accelerator of risk. So partly it's we just don't know above 45, but below 45, you can enroll CKD without proteinuria. Otherwise, with proteinuria, other than the exclusions, it's indicated for a broad population of non-diabetic CKD. Thank you.
I've got another question here. Involving patients in their own care, what patient engagement strategies can you use in primary care to improve kidney outcomes? And that is to my primary care colleagues, Mehmet and Baruch. What strategies would you use to engage primary care teams
Yeah.
to improve kidney outcomes?
Yeah, that is a really very good question, and also it's a matter of the non-communicable diseases as a whole. I mean, not only the kidney, but it's related with the life. Um, they usually call it a therapeutic patient education. I think that there should be kind of activities routinely on behalf of a general practitioner in the primary care, just trying to help our patients and the audience and the normal population also to have the lifestyle modifications and interventions sometimes when they have the disease. But before they have the disease, I think that will be very good if we can just increase the health literacy and the therapeutic patient education activities just to empower our patients and the population. This is how we look at as a public health, and the WHO, World Health Organization, is also uh, preparing such kind of guidelines, which we, as the primary care physicians and our team, can have a benefit for that. I think those are not rocket science. Those are all depending on the really healthy lifestyle, which is every JP has kind of um, good knowledge as I see. And but maybe we can just add a few things which are new developments other than the therapeutic pharmaceutical preparates. Then I think we can just talk about healthy diet and exercise and good lifestyle, enough sleep, and stress, dealing with the stress in a right way, and also I think enough fluid intake and restriction, not maybe restriction, but not using salt, additional salt in Mediterranean countries, especially it's very important because, once you start to eat, you just put the salt in everywhere there is still salt in the Mediterranean region. Those kind of measures should be which I thought immediately.
And
Yeah.
Sam, if I
Yeah.
may add, to
Yeah.
this point, this is a very important point. The engagement of our patients is very important to the process. So just to give you, for example, a practical tip, how I use this engagement. Usually, if I see a reduced EGFR, I'm saying to the patient in his language, look, your kidneys are now a little bit damaged. They are working only 50%, 60%. And he is very surprised. He even doesn't know it. And he said to me, Doctor, what can we do together? How can we approach together the engagement and to rescue my kidneys? Then I consult him with some new, maybe to give him new medication, but I consult him also to go to a dietitian on to have also the protein restriction in his food and all those other processes in lifestyle. So speaking with the patients in their language and explain them in their language helps very much.
Thank you very much. There is another question here which I will direct to Louise. The question says, can compromised immunity result or worsen chronic kidney disease in type 1 diabetes?
Thank you for that question. And it's a brilliant question. I might even expand it. We're really seeing more and more involving the immune system. I heard a mention of stress as one of the 8 pillars of health, and who knows what all that stress is. But we are seeing more inflammatory mediators that are part of our immune system, the TNA, the IL-6, TR2s, all increased with the kidney disease, as we see with other vascular disease. And you will be starting to see more evidence about blocking the immune system in kidney disease in general, not just type 1. So you'll see some of these MABs, canacluzumab, I have to practice saying these still, colchicine, we'll see coming up after some of the other vascular trials as that sort of having an anti-inflammatory. So this is a key area. It didn't make the new guidelines that I read, but certainly the evidence is growing in vascular disease of blocking this inflammation, which is driven by the immune system. And we'll be starting to see some expansion of medications into that area, including all of these biologics as we come. The studies are showing it reduces the inflammatory markers and early indicators that it reduces disease. So I think keep an eye on things like colchicine. Some of these newer MABs will be coming out for CKD over the next 5 years. I'd say it's really accelerating. So brilliant question. And again, back to those big pillars of health that we talk about, the blood pressure, diabetes, etc. Stress, as we said, is one of those pillars, as well as sleep. So I think sometimes we talk to people about this broadly, and maybe one is more pertinent to them at that time, but definitely an important thing to watch for in the literature and in the upcoming guidelines after this year. Thank you.
Thank you. There's still a lot of questions, but I don't know if we've got time to squeeze in another one. There's just a question here again that is on young people, causes of chronic kidney disease in the young patients under the age of 20. Do we have any ideas on this?
I'll take that one. I did see that before, so thank you. I think this is a brilliant question. A couple things. I would suggest that certainly a good diet history and the use of creatine as a protein supplement. So make sure that you've reviewed all of those things as what they're doing. We do see that this person does have a raised BMI, and we know that obesity is an independent risk factor for kidney disease. So it is kind of all brought together with diabetes and hypertension, but independently, just obesity does increase that risk. However, creatinine is not a good marker of kidney disease in the extremes of weight, either the lower weight or the higher weight. And I'm not sure what the prevalence of use is of cystatin C, which is not based on muscle mass, but in those extremes of weight, it is recommended to do a cystatin C, and this is in the KDIGO guidelines. So if they're at those extremes of weight, or you're right in that 60 mark, you could validate it by doing a cystatin C eGFR. So they measure the cystatin C independent of muscle mass. So I would start with those two questions. Other than that, a very good family history, looking for genetic causes such as Alports, looking for congenital causes, although you said the ultrasound was normal. In women, we do see some reflux nephropathy that didn't get picked up. So ask about history of UTIs when they were younger and seeing of any story there. There might be some scarring that's not yet evident on the ultrasound that you would see. Again, review medications, a lot of NSAID use in this population. Again, other illicit drugs that may be brought forward with that. I think very important to do that, to look at it. So again, look at, are you using the right marker? Consider a cystatin C if at extremes of weight. A very good family history, doing a good childhood history. I mean, I don't know this person, but if they've had any pregnancies, that would also be helpful. Medications, and then again, screening for other things. But I would definitely start with those basics before I started into a whole SLE or other workup without any other symptoms. Thank you.
Louise, what is the most common cause you see in those youngest people with chronic kidney disease?
Yeah, I would say it is either congenital, that when you do the ultrasound, there is a smaller kidney or an absent kidney. So we're really running on one engine, although the eGFR should be good. There might be some stress. Use of creatine as a protein supplement or high protein diets that these younger people are often doing. Some hereditary disease that we haven't picked up yet, that there is a family history. We have a high immigration population, as you do. So it's sometimes really hard to get that. And then obesity independent of itself and just their lifestyle. I think we're seeing higher risk of kidney stones in very young people, higher risk of obesity, higher rates of hypertension. So I think we're just moving that curve. Instead of seeing things in their 40s, unfortunately, we're starting to see them earlier.
Thank you.
Thank you very much. So I think we're running behind time now. Baruch, I'll hand over to you now to do the concluding statements,
Yes,
please.
thank you very much. Thank you very much. So we are actually approaching to the end of our journey. And some points I would like to have for our summary. What are the take-home messages? So first of all, early management with lifestyle intervention and appropriate pharmacological treatment can prevent renal deterioration. RAS inhibitors, SGLT2 inhibitors, and MRAs have a crucial role in addressing these conditions together or on their own. Tools such as the CKD one-pager can be used to provide guidance on identification and intervention for CKD in primary care. And I will present now the one-pager toolkit in our next slide. You see, this is a very practical and helpful a toolkit, one pager that you can use it in your clinics to identify, to stratify, and to treat the patients with CKD. This kind of toolkit is endorsed by 4 big organizations: the International Society of Nephrology, the CKD, the WONCA Europe, and the Primary Care Diabetes Europe. So please use these toolkits. It's very easy and portable. I would like to remind you our next activities on CKD for primary care management. Our independent educational program will provide decision support and educational tools to guide primary care practitioners in a real-world clinical context. Interactive simulated patient-doctor set scenario are enhanced with expert-led discussion and commentary and supplement of those, and will be coming soon. Please be in contact and follow up our new activities. And last but not least, I would like to thank today our faculty members that worked hard to convince you that we have to treat early as possible the CKD patients in our clinics. So this is Professor Samuel Seidu. He is a professor of primary care, diabetes and cardiometabolic medicine, University of Leicester, United Kingdom. Louise, a professor of medicine and epidemiology, London Health Science Centre, Canada, and Professor Mehmet Ungan, professor family physician in Ankara University, Turkey, and myself, Baruch Itzhak, who am a diabetologist and specialist in family medicine at the Clalit Health Services Technion Faculty of Medicine, Haifa, Israel. Thank you again, all of you, and hope to see you soon. Good luck.